Hi, this is Mrs. Terry, and I am going to record for you Unit 2. And Unit 2 includes chapters 15, 16, and 17 in your textbook, and then you have a PowerPoint. I'm going to try to move through this rapidly this morning so that it won't be so long that it will be hard for you to get through. So in chapter 15, we talk about drugs that affect urine output and very important medications. You'll probably be given a lot of those. Make sure, as I've told you before, you know the key terms in the front of each chapter. You know the key points in the back as well as the critical thinking activities. So in page 240, slide 15.1 shows the pathophysiology of how and where diuretics affect the different parts of the kidney. And diuretics, the intended response when given a diuretic is to decrease edema or swelling and to lower blood pressure. So patients will come in with edema, weight gain, shortness of breath, high blood pressure, etc., and they may be given a diuretic. The patient's blood volume is reduced because the kidneys are excreting more water and electrolytes. So the electrolyte component is very important when we discuss diuretics. Sodium and potassium in particular and are very, very important when it comes to giving diuretics. You've got to watch the sodium and potassium levels of your patients. So when excretion occurs, it increases urine output. So make sure the path to the bathroom is clear. Make sure that you've gotten the call bell in reach, that you've told the patient to call for help when they need to get up to the bathroom. Avoid giving this medication at night so the patient's not up all night long. And weigh the patient to monitor for weight loss, which is an expected response. Weight loss is, but you still need to monitor it. So complications: hypokalemia, hyperkalemia, dehydration, hypovolemia, and hypotension. Very important complications, especially for the elderly. Diuretics are used most often to treat problems with the body retaining too much water or sodium or potassium. So if the patient has high sodium, then they probably will be given a diuretic. They're often prescribed for people who have high blood pressure, heart failure, kidney disease, and liver disease. So potassium imbalances, you always need to check the apical pulse of your patient, blood pressure, but a lab value of less than 3 on potassium is very dangerous. And you would give them a potassium supplement, either orally or IV, which is K-dur, so K being the potassium, to help you remember that. So K-dur, the chemical name for potassium, of course, is K+. And you would give that, or you would increase their diet of potassium-rich foods. Hyperkalemia greater than 6 is very dangerous, and you would give, a patient might come into the hospital, especially a renal patient, and they would be hyperkalemic, and we would give a K-exolate, normally enema, or you can give it orally. Also, please remember that salt substitutes contain sodium. And so if your patient is on diuretics, you need to remind them about salt substitutes. So the 3 types of diuretics on page 242, thiazide diuretics, loop diuretics, and potassium-sparing diuretics. And also where they act on which part of the kidney, as I discussed on table 15.1. Side effects, certainly if you're decreasing volume in a patient, is orthostatic hypotension, and you know what that means. When a patient is laying down and they get ready to sit up, they may be dizzy, or they're in a sitting position in a chair and they're going to stand up, then they may get dizzy and even faint because their blood pressure drops when they change their position due to that low blood volume. And certainly patients can experience dehydration, one of the most common side effects if they're taking a diuretic. They have dry mouth, thirst, dizziness, lethargy, and hypotension. Lab values, you need to make sure you know those, as well as you know the terms: hypertension, hypotension, hypokalemia, hyperkalemia, that's a misspelled word, hyponatremia, and hypernatremia. And then table 1.4, as we talked about before, the normal lab values of electrolytes. You need to know those. So we talk about potassium sparing diuretics, and that's not quite in order with your book, but as the name implies, they spare potassium. So it slows the sodium pump, so more sodium and water are excreted, but they do not lose potassium. They spare it. So a patient then would be at risk for hyperkalemia. And this is not used for patients who have gout, kidney disease, or kidney stones, or renal insufficiency. Now, if they get hyperkalemia, it can be very serious. Potassium is a very important element in the heart, so they can get tachycardia and twitching and muscle twitching heart arrhythmias. So very, very dangerous. Hyperkalemia, very, very dangerous. Those are potassium sparing diuretics. So common side effects are hypotension, low sodium because you're excreting sodium, vomiting, diarrhea, and the increased potassium. Thiazide diuretics on page 242 of your book. They slow down or turn off the salt pumps in the nephron tubes furthest from the capillaries. They cause more sodium, potassium, and water to stay in the urine and leave through urination. So you lose sodium, water, and potassium in thiazide diuretics. And this action reduces blood volume and lowers blood pressure. It's a commonly prescribed medication, diureal, hydrochlorothiazide, etc. Urine output is increased, urine is lighter in color, and blood pressure is lower. So they're going to avoid more sodium and potassium out. They can cause increased thirst, heart rate, mood changes, muscle cramps, nausea, vomiting, fatigue, weak pulses, and postural hypotension. Need to make sure you know all of those side effects. Then we have loop diuretics. Loop diuretics are the most powerful of the diuretics, so you need to know that. They're the most powerful. Loop diuretics are, and they slow down or turn off the sodium pumps in the nephron tube, which is a different place than the thiazide diuretics. They cause more sodium, potassium, and water to stay in the urine and leave through urination, but they're more powerful than thiazide. They're ototoxic, so they can be toxic to the hearing and can cause tinnitus and hearing loss. That's a very serious adverse effect. There's a high potential here for hypovolemia and hypokalemia, so you need to always check potassium levels because you are urinating out the potassium. It's not potassium sparing like that first one we talked about. So the patient can be dizzy due to blood pressure being low, low potassium, low sodium. Lasix is a very common loop diuretic. Bumex, Demodex, those are all very common. So you need to make sure you're checking your potassium and sodium levels before you give patients these medications. And then lastly in this chapter we talked just briefly about overactive bladder medications. Diprovan is one that you hear. Detrol is another one. These are given for overactive or spasmodic bladders, and they help calm those spasms. Okay, I think that's about it. That was fast, but for chapter 15, and you need to make sure, as I told you, to know it frontward and backward. Chapter 16, drug therapy for hypertension. There are numerous slides here that talk about the pathophysiology of the heart and water pressure and the pump and vasodilation, etc. A good way just to know it is think of a water hose, and if it's clear, how the water can go through it. If it's clogged, like a clogged artery, and then the water has problems going through it. Normal arteries constrict and dilate. If there are plaque in those arteries, then they cannot constrict and dilate smoothly. So it's important to understand that pathophysiology. As well as you think of a fire hydrant and the pressure that the water comes out. It's the same way with the heart, and the heart pumps that blood out. If the artery is clogged, then the heart is having to push against that artery and work harder. That increases the blood pressure. It's called systemic vascular resistance, and it's there in one of your PowerPoints. But if the systemic vascular resistance is high, then that means the heart is having to pump harder to get the blood through the system. And if that happens, then the blood pressure does what? Rises. The heart over time is a muscle, and it works hard, and what does it do then? It enlarges because it's worked so hard over all the years, and therefore patients can have congestive heart failure. So think of the pathophysiology, review those PowerPoint slides and sort of understand that in your mind. Talk to your classmates, and so that you all sort of understand that, you know what hypotension is, what hypertension is, what are the parameters. Usually less than 100/50 is hypotension, and so you sort of need to understand all that to get that concept in your minds when you're given these medications. So untreated hypertension is the #1 cause of heart failure, and it's rampant in our society. It causes kidney failure, congestive heart failure, strokes, and MIs. Untreated hypertension. So blood pressure is very important to prevent. Patients should not stop taking a blood pressure medication. It's usually a lifelong medication. Once they're on it, they need to take it at the same time every day, and they don't need to skip a dose. And if you're giving it to a patient for the first time, you need to make sure you're checking on them and you're helping them up to the bathroom because they can faint on you. They can lower their blood pressure, bottom out their blood pressure, and faint on you. And let's see. Types of antihypertensive drugs, that's on page 2. Well, lifestyle changes on page 253. Certainly, if a patient is hypertensive or has any kind of heart failure, they need to decrease their salt, decrease their fat, exercise, lose weight, quit smoking, decrease their alcohol, and decrease certainly stress in their life. So on page 256 are the types of antihypertensive drugs: diuretics, ACE inhibitors, ARBs, calcium channel blockers, beta blockers, alpha beta blockers, central acting agents, and direct vasodilators. Need to know every one of those categories and know what they do that helps decrease blood pressure. And ACE inhibitors are, let's see, make sure I'm on the right page, block the absorption of substances that help constrict or narrow blood vessels. They help decrease the buildup of water and salt in the body and body tissues. Popular ones are captopril, lisinopril, benazepril. If you notice, they all end in PRIL. See the memory jogger there to the right of the page on page 257. So that will help you learn the generic name for ACE inhibitors. All end in PRIL. So the intended responses of ACE inhibitors are the production of angiotensin II is decreased, vasodilation, so dilation is increased, excessive tissue water and salt are decreased, blood pressure is lowered, and workload on the heart is decreased. Adverse effects certainly can be hoarseness or swelling around the throat. If that happens, this is a very serious adverse effect and can be called angioedema. You need to notify the physician. Very, very serious, and we have a picture in our PowerPoints of someone who is experiencing that adverse effect. These are often given with patients who have heart failure, kidney disease, and diabetes. Usually the first doses of an ACE inhibitor are lower when the patient is taking another diuretic. So you will see that your patients may take a diuretic and a blood pressure medicine. So then we have ARBs, angiotensin II receptor blockers. These usually end in sartan, and that is on page 259. So losartan, valsartan, etc. These are ARBs. They block the effects of angiotensin II, and by directly blocking the binding of angiotensin II to the receptors. These drugs may be given also with diuretics. Vasodilation of blood vessels is increased, excessive body water and salt are decreased, blood pressure is lowered, and workload on the heart is decreased. Side effects: dizziness, headache, hypotension, diarrhea, and hyperkalemia. Okay, then we talk about calcium channel blockers. And these block calcium from entering the muscle cells of the heart. Calcium, magnesium, sodium, potassium, those are all very important elements when it comes to the heart, the contraction of the heart, that sort of thing. But these block, calcium channel blockers block calcium, and that causes a decrease in the contraction of the heart and dilates or widens the arteries. Procardia, Cardizem, Kaline, Norvasc are all important calcium channel blockers. They can cause tachycardia, so you must check your patient's heart rate and hypotension. So as I told you, calcium, if you start messing with the calcium in the heart, then you can cause tachycardia. And, okay, moving right along, we talk about beta blockers. They decrease the heart rate, decrease the contraction and the workload of the heart, and therefore decrease blood pressure. That is found on page 262. They block epinephrine or adrenaline, and by doing that, they slow the rate and force of contraction of the heart. Beta blockers usually end in OLOL. So you have atenolol, labetalol, metoprolol. Those end in OLOL. So heart rate is decreased, force of contraction is decreased, work of the heart is decreased, and the blood pressure is lowered. Beta blockers, very, very common. A side effect, an adverse effect might be chest pain, which is always a bad sign, and you need to pay attention if your patient starts saying that they have that. Depression could be fatigue, but especially depression, and you need to assess if they've ever been on any other kind of medicine for depression. You need to be aware of that. Never stop taking your beta blocker, that you don't contact the physician. Make sure your patient understands that, because the depression can get worse, or the blood pressure problems can get worse. Alpha blockers, they block the smooth muscle and the arteries. This relaxes the blood vessels and leads to an increase in blood flow and lower blood pressure. Cardura, Minipress, and Hytran are common alpha blockers. Then you have alpha beta blockers. They relax blood vessels like alpha blockers and slow the heart rate and decrease the force of contraction. Coreg is a common one. Suddenly stopping these can be life-threatening heart arrhythmias and hypertension or chest pain, bradycardia, heart failure. A lot of things can happen. You just cannot abruptly stop these medications, alpha beta blockers or any of the other one. Then you have central acting adrenergic agents, the CNS system. They stimulate the CNS system receptors to decrease the constriction of blood vessels, so they're going to dilate the arteries and lower the blood pressure. And Dopamet is a common one. Catapress, common one. Those are usually given in ICU. And then you have direct vasodilators, and it does just what the word says. It dilates directly. and presaline, nipride. Those are usually ICU medicines. Also, they can cause reflex tachycardia or increased heart rate. So it can be a very dangerous medication. And we talked about angioedema. Moving right along to chapter 17, drug therapy for heart failure. There are two types of heart failure, right-sided, left-sided heart failure, and that depends on then this whichever side of the ventricle is failing, then that is the sign and symptoms that you will see. So on page 275 are signs and symptoms of left-sided heart failure, and that usually you'll see a lot of pulmonary issues and decreased cardiac output. So their urine output will decrease, confusion, restlessness, tachycardia. They'll get a cough, crackles and wheezes when you auscultate their lungs. That is left-sided heart failure. This is the most common type of heart failure. Right-sided heart failure is a systemic issue. Jugular vein distension, dependent edema, swollen hands and fingers, increased urine output, increased blood pressure, etc. That is right-sided. And so patients with heart failure, we certainly will watch their blood pressure, their pulse, their weight gain, or we monitor their weight very closely. Heart failure is caused by the decreased contractility of the myocardium of the left ventricle, which causes a backup of blood into the lungs, and the right ventricle causes a backup into the right side, or the venous circulation. And the three primary characteristics are the force of contraction of the heart, how hard or how it's not able to contract hard. It affects the heart rate and the speed of conduction, of impulse conduction, electrical conduction through the heart. And again, you want to stop smoking, salt, alcohol, start exercising. Same things as hypertension. Drugs used to treat heart failure are listed on page 278. ACE inhibitors, beta blockers, vasodilators, cardiac glycosides, diuretics, peptides, and positive inotropes. And as you see, some of those are the same medicines used to treat hypertension. ACE inhibitors are often among the first drugs used to treat heart failure, and that can be captopril, zestril, quinapril. Those end in PRIL. Beta blockers we've talked about before, and let me see your PowerPoint. Well, we've talked about they block adrenaline or epinephrine on the heart. They decrease the rate and force of contraction, so they allow the heart some rest, if lack for a better word. It doesn't have to pump so hard, and doesn't have to pump against the vascular resistance, the systemic vascular resistance that we talked about earlier. Low pressure is one, reduces the heart rate, used very cautiously with other heart meds, and do not stop abruptly. Vasodilators are used for hypertension and heart failure. The most common side effect is headache and hypotension. Presaline, Iserdil. Iserdil is used for severe congestive heart failure, nitroglycerin. So on page 281 are some information about vasodilators and nitroglycerin, and you can give nitroglycerin tablets sublingually under their tongue. It must tingle in order to know that it's effective. You keep it in a little amber bottle. After one, if the patient is still having chest pain or severe signs and symptoms, you need to notify the doctor. After 3, you need to be calling the EMS, and they don't need to eat anything until that tablet is dissolved. You can also give nitroglycerin ointment, and there's an example there of the little piece of paper that you measure the ointment out and put it on the skin and put a little piece of tape on it. Or there's a nitroglycerin patch, and you need to rotate the sites. Also, if you're giving the ointment or the patch, you need to make sure you find the previous one on the patient. It could be stuck on their gown or something. You need to find it, get rid of it, because it might have leftover meds on it, and the patient would get too much medication. You need to always weigh your patient. Cardiac glycosides, that or digoxin, that helps improve heart failure by slowing down the heart rate and allowing more time for the ventricles to fill. Digoxin is a common one. There's a very small window on digoxin to prevent dig toxicity, we call it. So you always have to be watching their dig level. Also, the thing about digoxin, you need to make sure every time you give lanoxin or digoxin that you take their apical pulse for 1 full minute, and you record that normally on your MAR. And you have to do that every time you give it, because if the heart rate is lower than 60, you hold that dose and notify the doctor you're getting that heart too slow. Adverse effects, diarrhea, vision problems, loss of appetite, that sort of thing. Cardiac when we talk about that, lanoxin. Check their potassium levels, monitor their weight, etc. Peptides is a hormone that is produced by the heart ventricles, and that is given for heart failure. Works on the kidney and excretes sodium in water and causes vasodilation. Usually that's given in ICU. Positive inotropes is a heart pump drug, and those are usually given in ICU. Also, dobutamine is a very common one, and the intended results are listed on page 285. I won't go through those right now. And then potassium and magnesium. Potassium and magnesium are two elements that are very common in the heart, and you see patients sometimes are put on magnesium drips, or nowadays they're given magnesium orally to help with that heart failure. And they can cause nausea, vomiting, diarrhea, abdominal discomfort, etc. So make sure you know these meds, categories of meds, common side effects, and their intended actions. Congestive heart failure exacerbation is on page 289. This is that. I thought somewhere. Anyway, if you have a weight gain of more than 3 pounds a week, that can tell the patient that their heart failure is getting worse. If they're getting increased peripheral edema, increased shortness of breath, and of course increased fatigue. All of those are common side effects that you need to contact the physician and tell the patient you think their congestive heart failure is getting worse. So that is rapidly through those chapters. Please know your key points, and I hope this helps. Thank you.